Hello, everyone. Welcome to the mental status exam lecture. So this is one of your assignments this week. You will be completing a mental status exam. Most of this information is already provided for you in the MSE info of your case study, and you just kind of have to know where to put it. You'll also be responsible for formulating your own assessment of the information, as well as making a plan moving forward. So this is going to be something that you're going to pull suggestions from the MSE and formulate a plan moving forward. So we're going to assume that all of our case studies still have time in treatment. And so in the plan, we're going to want to focus on things that have not been met on the treatment plan yet, or any assignments that that we think would be beneficial, or groups that we think that might benefit them. And that will make more sense running through here. So give me one second. So again, we will have examples throughout, and feel free to email me or set up a time to meet with me if you have any further questions. Let's go ahead and get started. So the mental status exam, or MSE, is the psychological equivalent of a physical exam that describes the mental state and behaviors of the person being seen. It includes both objective observations of the counselor or case manager and subjective descriptions given by the patient or client. So as I stated before in the DAP note lecture, so MSEs are likely going to be used, especially if you work in a medical setting where psychiatry is offered, because this information is pertinent to prescribing medication, as well as pertinent for assessing mental health symptoms across the treatment episode. So you may not use this, like I said, in the chemical dependency specific realm of treatment, but you very well may use this in behavioral health, especially if there's some kind of medical or medication component involved. So why use MSEs? So the MSE provides information for diagnosis and assessment of mental health and substance use disorders. This information is then utilized to develop the treatment plan. So typically during the biopsychosocial assessment, it would include a section for the MSE. However, the way that this class is structured, we didn't do it that way. We're not being introduced to MSEs until now, obviously. But keep in mind that it is typically a section of the BPS, and we would use it to hone in on symptoms or strategies to alleviate symptoms in the treatment plan. So the mental status exam provides a snapshot at a point in time, so that if another provider sees your patient, it allows them to determine if the client's status has changed without previously seeing them. So again, we're documenting progress throughout time here. To properly assess the MSE, information about the client's history is needed, including education, cultural, and social factors, which you've collected during the BPS. So a couple of the features of mental status exams. The first is inferential observation. So again, this is the clinician's professional opinion, if you will. So how the clinician describes what they've observed by stating facts and details with as little as interpretation as possible. So let me unpack that a little bit. So again, when we're making an inference, we do have to have evidence supporting that inference, okay? So we can't say that a patient appears anxious without having the evidence behind that, or the patient appears, whatever the case may be, we have to have some type of evidence attached to it. So for example, patients seem nervous, evidenced by flushed cheeks, bouncing their knee rapidly, and pressured speech. So pressured speech just means talking really fast, like I do during some of my videos due to nervousness. But those are that's what's telling about what we are inferencing, okay? We also use subjective description. So this is how the patient describes their symptoms, stressors, and experiences. So the different components of the MSE, so we're going to be assessing appearance, the physical appearance of the patient, how they interact. Are they sitting during the interview? Or are they pacing back and forth? What are they wearing? Is it appropriate for the setting? We're also going to assess behavior to some degree. which we'll unpack here in a few minutes. We will not be assessing speech. This is typically something, so psychiatrists and medical doctors also conduct MSEs. And so the speech part, some clinicians would assess that, but for the most part, that's going to be something that's included in a doctor's mental status exam. So we won't be covering speech, thought process, or cognition in this assessment, in this assignment, but I will be discussing them at the end of this lecture. We're also going to assess mood. Like I said, in our program, we use a Likert scale. So on a scale of 1 to 10, how would you rate your mood today? 1 being the worst ever, 10 being the best. I also like to get a patient's report on what their mood is. So they might say that they're anxious or happy or energetic or sad or angry. So I would usually put that in quotes next to the number, like 7 out of 10, quote, anxious, okay? I think in your MSE info, it just gives a number out of 10. It might also give a mood in quotes, so that is where you would want to put that piece. We're also going to assess affect, so this is our observation of mood, which I'll go into here in a few minutes. We're also going to be addressing the thought content component of the MSE. So this is what the patient states, what the patient's going through, what they're experiencing. Like I said, we will not be going over cognition, but I will explain it briefly. And then we're going to assess the patient's insight and judgment. So is the patient insightful about their experience and their symptoms and what they need to be accountable for? Do they have the ability to judge accurately? Okay. So when assessing appearance, we may or may not want to assess whether they appear their stated age. That is not a requirement of this assignment, but sometimes it can be telling if the patient appears older or younger. This is not typically something that I include, but you may be required to include in your agency. And then the bulk of it is physical characteristics. So are there any unique marks on the body? So we really want to be attentive to this if self-injurious behavior is involved. Build, again, something that we don't typically assess. I guess you could if you wanted to add it in. I know it's not in the info, but if you wanted to make up that piece, you certainly could. But again, we're just stating, is their attire appropriate for the setting? And are they able to sit for the interview? That's basically what we're going to cover here. But especially during an initial MSE, you might want to specify if they had glasses, hearing devices, or use a wheelchair or cane or any kind of walking assisted devices. We also want to assess if they look clean. So do they look unkempt? Are they casually or formally dressed? So a good example for this piece of the MSE might be patient appears casually dressed, appropriate for setting, sits for interview. Okay. So again, is the clothing appropriate for the weather or the setting? I did tell a story during one of the other lectures about having a patient come in the winter when there was snow in the weather report, um, coming in a bathing suit and flip-flops and lots and lots of makeup. And so that, because she was in a manic state and that was not her norm, that was an important thing to include in the assessment. And it did kind of help the doctor determine where she was at in her stages of mood. Okay. So we're also going to be assessing behavior only regarding ADL. So of course we're going to assess behavior outside of that, but for this piece specifically, the ADL piece, we are going to assess whether the patient's capable of cooking, cleaning, grooming, or providing hygiene for themselves, working, parenting, driving, okay? So an example of this is grooming and hygiene appear to be intact. Patient reports, quote, aversion to showering currently. Patient reports, quote, I don't like the way the water feels on my skin. Patient reports no issues tending to other ADL. So they're able to cook for themselves, they're able to clean, and some people are more cleanly than others, and that's okay. So we just want to, it's comparison to the baseline. So if they weren't able to clean, but typically, historically, throughout their lives, they were a very clean person, and now they're depressed, so they haven't been giving that much attention. We want to assess the progress of that throughout treatment. Okay. So the mood, so this will always be the patient's stated feeling or mood. It should always be in quotes, again, unless we're using the Likert scale, which some of you may be using in your case studies. Add as many feeling words as they are willing to give and take some time to explore this, okay? So if they say they feel angry, we might want to unpack that a little bit more to kind of pull out any secondary emotions or primary emotions that might be telling of the anger. It would also be beneficial for us to familiarize different feelings and emotions to assist in the patient understanding mood. And so this is called a feelings wheel. So the major feelings that we are all pretty much able to identify are here in the middle, and then it branches out to uh, other feelings that could be more accurately descriptive regarding the primary emotions such as anger, joy, peace, shame. And so take a look at this feelings wheel and try to expand your vocabulary of emotions and feelings, because that will be really helpful in assessing patients. You can also save this photo in the regular PowerPoint located underneath this video in the module. So assessing affect. So this can be kind of confusing, but what I will say is that I would like one affect assessment from each of these sections. So I want to know type, range, congruency, and stability. So in type, you can pick through any of these. There are more, but this is what we'll be looking at for this assignment. So euthemic, so do they have a normal mood? Are they dysphoric, which would be depressed, irritable, or angry? So negative emotions. Euthemic is positive emotions. Dysphoria is negative emotions. Euphoric, so are they elevated? Elated, this might be persistent or connected to mania, so that is something that we need to document. Are they anxious? Okay. And then we want to assess their range of emotions. So some people, especially folks with psychotic disorders, they have a flat or blunted affect. So people who are depressed also tend to have a flat affect at times. So this is just an emotionless face. There's not much going on. They're not expressive or responsive in how they speak or how they answer questions. Sometimes they're restricted. They can't, like maybe they're unable to smile, or they don't, based on your inference, it doesn't seem like they're able to smile or express positively. So that's what we're talking about with range. Do they have a full range of emotions? Do they have expression in their face? If yes, you can put normal or full. If no, flat or blunted could go there. Some people also use this lability label in the range, and you're welcome to do that. Labile just means they're crying easily, or they get angered or upset easily throughout the conversation. We also want to see if the what they're reporting is congruent. Okay, so does the affect match what the patient is reporting? So we're going to write either congruent or incongruent. So for instance, if somebody says they're happy, but they're crying, not happy tears, that would be incongruent. Or if they're reporting, but they're sad, but they're elevated and euphoric, that would be incongruent. If they say that they're anxious and they seem irritable and angry, that would be congruent. It is in alignment with what they're reporting. We also want to assess whether they're stable or labile. So stable means stable mood. They're able to use expressions throughout the session. They're not easily set off, if you will. They don't start crying randomly or throwing things or getting elevated or upset throughout the session. They're stable, okay? So assessing thought content. So again, this is going to refer to the themes that occupy the client's thoughts. So we are going to, so in addition to writing what the patient's reporting during thought content, we do, if it's possible, we want to use words such as, well, I'll show you an example of the words on the next slide, but let's go over the example. So patient appears to be ruminative regarding her recent breakup. So ruminative just means kind of obsessed, just constantly focused on that thing. Patient stated, quote, "I just don't understand why they would leave me," multiple times throughout session, even when the topic of conversation would change. So in the thought content, we do want to include our inference of what the patient's reporting. So another example is patient appears preoccupied regarding a recent eviction. She states, "I have no idea what I'm going to do." So the patient seems unable to kind of see beyond that problem because it's so impactful. So that's when we would use a word like preoccupied. So some other thought content examples. So these are things that if they are present, we need to document them. Sometimes they won't be present and we'll just be reporting or recording what the patient reports, but many times this will be the case. So we want to talk if they have any preoccupation. So are they obsessing over anything? Are they ruminating? Are they really stuck on something? So common things that you'll see are suicidal or homicidal ideation, perseverations, obsessions, or compulsions. So we want to speak to that if it's possible. We also want to sometimes we will work with patients who are best described as delusional. So reality, they have misinterpretations of reality. That is something that we want to assess. Any ideas of reference or oh my gosh, misinterpretation of incidents and events in the world having direct personal reference to the patient. So sometimes folks will feel, so for example, some folks who have diagnoses of schizophrenia or schizoaffective disorder or some kind of psychotic feature to their mental health, they may experience misinterpretation in the sense of if somebody on the street comes and offers them help, they might assume that they're being gang stalked, for instance. So people just watching them and reporting to some higher body like the government. So that would be a misinterpretation of incidents or a delusion. That is something that we want to include. We want to see if they're experiencing any hallucinations, if they're experiencing any kind of depersonalization or derealization, so feeling like they're in a dream or feeling like they're in a video game, something that you would put. If they say that aliens are controlling them or something like that, you're certainly going to add that in the thought content. You're going to include any kind of grandiosity or manic. So this is a person. So they would say, sometimes I have patients report that the president or a celebrity is in love with them and they're just waiting for them. That's something that we would want to add in the thought content as well. And any kind of persecutory thoughts, so that people are trying to harm them or watching them on their computer, any kind of paranoid thoughts like that, that is something that we're going to want to include in the thought content. Assessing socialization. So we will go over this more specifically in the MSE assignment video, but we want to address whether they have adequate social support. So this is in the program and outside of the program. So we want to assess, are they socializing in groups? Do they share appropriately? Are they making healthy social connections with peers? Or are they trying to date somebody in the program? Are they fraternizing? So that is something that we highly suggest not doing in the program, is hooking up romantically with other folks. And so if we noticed that that was happening or had a report of that happening, we would include that here. Um, Also addressing if they're attending support groups, and if they do not have adequate social support, because we're also assessing who's supporting them at home or outside of the program, then we would assess if they're willing to explore social support and start including resources or referrals to those social support networks if possible. So sleep and appetite, again, these are one of the two major drivers of mental health. So it's something that we are going to focus on in every mental status exam to see how it's improving or deteriorating. So some things we might include are how long is the patient sleeping each night or during the day? When are they sleeping? If patient can only sleep during the day, that might be really telling about PTSD symptoms or anxiety. So we want to make sure that we include that. Are they having trouble falling or staying asleep? Do they experience nightmares or other interruptions? How has this changed since intake? Also, how much is the patient eating? How many times per day? How has that changed? Are they eating whole foods or full meals? Are they having any experiencing food insecurity, or is food inaccessible to them, or healthy food? If so, we can provide them with resources for food banks. Or other resources. We have some nutrition classes that we offer on eating healthy on a budget. And so making sure that we hook them up with the resources that we're able to. Also, if your patient has any eating disorder type symptoms, this is something that you would want to address in the appetite section also. Are they engaging in binging or purging or restricting? Those are things that you would also want to cover in that section. Assessing medication. So we want to see, is the patient taking meds as prescribed? Are they experiencing any side effects? Have they noticed any changes? Typically medications take anywhere from 4 to 8 weeks to start working effectively, but some people notice changes pretty quickly, and so we want to just assess that progress throughout treatment. And then also something that we might ask here is if they want to meet with the doctor for another medication eval or initial med eval to see how their current medication regimen is working, or if they want to add something for sleep or anxiety. We would address that in this piece. When we're assessing psychotic symptoms, suicidal ideation, or homicidal ideation, so we have to cover all of these things. It is a Washington administrative rule in behavioral health treatment, so we want to ask if they're experiencing any hallucinations. Again, a good way to do that might be, are you hearing anything that I would be unable to hear, or seeing anything that I would be unable to see? Like I said, not everybody knows when they're experiencing hallucinations, but typically people know if other people around them are experiencing these sensory experiences also. And so that's a good way to frame the question, a trauma-informed type of way. Again, if they are experiencing homicidal or suicidal ideation, do they have plan or intent? If so, what is the plan? Okay, and do they have the means to do so? So we did talk about this during the MSE assignment. We need to consult a supervisor or the doctor if they have plan and or intent to die by suicide or to hurt or kill somebody else. And so with homicidal ideation, if they have plan or intent, we do have a duty to warn. So this includes calling the police station. Again, please talk to your supervisor before doing so. But most of the time what that looks like is making a report to the non-emergency police number so that they can notify the person or attempt to find the person that this person's threatening, to let them know that they have a threat against them. Okay. And if they have suicidal ideation, so this is really common for us to see with patients, just because somebody's thinking about attempting suicide doesn't mean that they're actually going to act on it. So there is a difference between, I think just about everybody thinks about suicide, maybe not necessarily acting on it, but oh, I wonder what this might feel better if I was dead, or maybe I wouldn't be in so much pain. It's the only way out. Okay, so a lot of us experience SI or suicidal ideation, but it gets really concerning when we actually have the plan's means or intent. If the patient has the plan or intent, they likely need a higher level of care, inpatient hospitalization, or to report to the emergency department to be evaluated. For each mental status exam, we will assess whether the patient is meeting treatment plan goals. So we're going to list what skills the patient has learned or what they have done to meet or work towards that treatment plan goal. So always refer back to the treatment plan to find the objectives. And here is an example. So the problem's depression. The objective was patient agrees to attend groups such as recovery from depression, coping with triggers, nourish to flourish, and med ed to help manage depression symptoms. So what we would say under this section on the MSE is patient attended recovery from depression and medication education. So you do not have to include your objective like I did for the example. This was just to show you how I would report progress on the objective. You just need to keep this piece, what the patient did to meet that objective on the assignment. So assessing insight and judgment. So insight, we're talking about awareness of their own illness and or situation. Do they have good insight as to what needs to be done to address their problems? Do they not? So something that we might say, patient appears to have good insight regarding mental health diagnosis and treatment. We also want to assess judgment, so the ability to anticipate the consequence of one's behavior, and this will go into the assessment section of the mental status exam. It is inferential and covers the following. Does the patient have or lack insight regarding mental health diagnosis, symptoms, or purpose of treatment? Is the patient motivated for change? Do they have an understanding of social and personal actions and how they impact themselves and others, if applicable? And do they have an awareness of how their behaviors and circumstances may be related to present difficulties? Okay, so we might say here, in addition to the comment on insight, we might say patient appears motivated, evidenced by XYZ, or the last two are not going to be required for the assignment, but I just wanted to put them there so you know that might be something that you see on an MSE in the future. Is are they aware of how their actions are influencing their reality, and that type of thing. Okay. In the planning section of the MSE, we will put steps necessary. Here we will put steps towards, I'm sorry, that was a typo. So anything we need to do moving forward, what needs to be done to address the treatment plan. This might be what the staff or agency is doing or offering, and what the patient plans or is willing to do. So this might include assignments, making appointments, attending classes, exploring social support, practicing skills, etc. So an example of this is staff will continue to encourage participation in the program. This writer provided patient with resources to obtain therapist. Patient agrees to attend at least one outside support group prior to discharge. Okay. So again, we're just going to quickly go over the couple components that are not included in the assignment, but just so you have the information. So sometimes we'll be asked to assess thought process, but again, this is mostly psychiatrists or psychologists or MDs that are doing this piece. So we would we would use the thought content to make an inference about thought process. Okay, so is their thought process logical and linear or coherent and goal directed, or are they not clear, unorganized, uncoherent? Okay. Some examples include circumstantial, which is providing unnecessary details, so they just go on and on and on before getting to the point. Tangential, so moving from thought to thought that relates in some way but never gets to the point. So I might be pressured and just talking about random things and I never get to the We never get to the reason why they're here in treatment. Loose, so shifting illogically between unrelated topics, flight of ideas, quickly moving from one idea to the other, thought blocking, where you just lose your thought, which happens to me a lot. Perseveration, so repetition of words, phrases, or ideas, and then word salad. We see this a lot in folks with schizophrenia or who are experiencing delusions or psychosis, where you can't really make out what they're saying. They're kind of mumbling, and sometimes you'll be able to get something out, but we call that word salad, which is kind of a weird clinical term. But kind of this mismatch of random words that don't really follow any kind of logical context. Also assessing speech, so based on how they talk, what's the rate, volume, is it pressured, are they fluent, are they speaking linearly, is the speech organized and focused on a topic, and is it understandable? Again, not something we're going to assess. And then assessing cognition, which takes a lot of skill, not something we're going to get even close to in this class. Something that we would look at is, do they have the ability to focus, sustain, and appropriately shift mental attention? Does their memory seem to be intact, short-term and long-term? And how abstract are they? How abstract or concrete are they? So for instance, some people really need tangible explanations and instructions that are really direct and to the point, and any kind of abstract or critical type thinking. Sometimes people have an issue with that. So that's something we would document there. And that is it for this MSE lecture. Again, please reach out to me if you need assistance with anything, and I look forward to reading your MSEs.